So our next presenter is Dr. Jean Park, who is an endocrinologist, diabetes and metabolism specialist at MedStar Good Samaritan Hospital. She has a special interest in diabetes prevention and treating diabetes and kidney disease, in patients with diabetes. And she is currently serving as a principal investigator for a big study that is looking at the effects of 4 different glucose-lowering medications when combined with metformin. And she is going to be talking, presenting to us about specifically research in kidney disease and diabetes. Dr. Park?
Well, thank you for the nice introduction, Corinne, and big thanks to the GUTS team for inviting me to talk about diabetes and the research that we are conducting. Next slide. So the timing couldn't have been any better. Kudos to the GUTS team for having me talk on American Diabetes Association Alert Day. This is observed annually on the 4th Tuesday in March, and this is where we sit. It's the one day to do a wake-up call, quote unquote. We want the American public to know about the seriousness of diabetes. We're encouraging all to take the diabetes risk test, and we will go through that later. We'll provide that opportunity later. And it's a time to learn about your family's history of diabetes. Next slide. And we also want to talk about the importance of research on this day. Clinical research studies play an important role in finding new treatments and approaches to manage diabetes. It has helped us discover ways to diagnose and prevent diabetes. Next slide. So before I go in further talking about diabetes and just providing general information, this is just a general outline of what I'll be talking about. Again, I'll be focusing more into diabetic kidney disease and management, clinical research. We have specific questions and we're trying to find specific answers. So this is where we are. To do this for today, I wanted to go over general information about diabetes, going through risks for diabetes, the potential complications of diabetes, and focusing in on diabetic kidney disease, and how we can prevent complications or stave off progression in diseases or complications from diabetes. Monitoring and controlling blood glucoses are very important, and we'll be going over that. And again, trying to find answers through clinical research in our center this way. Next slide. So this is some general background about diabetes. Diabetes unfortunately affects a number of Americans, 34.2 million Americans, or about 10.5% of the US population. And nearly 1 in 5 adults are living with diabetes and are unaware that they have the disease. So that is 7.3 million Americans. Next slide. So the sooner you know you're at risk, the sooner you can take the steps to prevent or manage diabetes and stave off progression of or developing complications. So what are the risks? One is if you have a family history of diabetes, you have a greater chance of developing type 2 diabetes. Other risks are if you're over the age of 45, are overweight, if you're not physically active, if you have a history of hypertension, a history of polycystic ovarian disease, a history of depression. So there's a list, a number of risks involved with diabetes, and we provided a link to those risk factors with this slide. I believe it's in the chat. And then you can see on the right side that there is a test that I mentioned earlier that you could take to look into your risk for type 2 diabetes. So when you go through, or if you go through this test, if you score a 5 or above, you are at high risk for type 2 diabetes. You should talk with a provider, look into further testing, which could include blood tests to assess further. If you score below a 5, you may be in the pre-diabetes category, but again, to talk about it with the provider would be very important to look into blood tests and further testing so that you can find out about your diagnosis if there is. Next slide. So diabetes, unfortunately, there's an increased risk for many serious health problems with the condition, but the good news is that with correct treatment, talking with your providers, finding out what's best for you, and following the lifestyle changes, it can really, really make an impact in preventing or delaying the onset of complications, such as nerve damage, which we call neuropathy, eye damage or retinopathy, or kidney damage or nephropathy. Next slide. So as mentioned earlier, I am going to focus more in the complications potentially with chronic kidney disease or nephropathy from diabetes. So what happens at the level of the kidneys with high blood sugars or uncontrolled blood sugars? This makes the kidneys filter out too much blood. There's increased pressure at the filters, I call it, or sieve, when I talk to patients and participants. And unfortunately, all this extra work, it's hard on the filters. And over many years, what can happen is that proteins that are useful, that are supposed to stay in the blood, can be lost in the urine. So very early on, what can be seen through testing is microalbuminuria, when there's small amounts of protein in the urine. And this can't be seen with the naked eye. There can't be changes that you see in how much you urinate or the quality of the urine, because I often get that question from patients and participants. Next slide. Some other information about diabetes and chronic kidney disease. Kidney disease or nephropathy is one of the most frequent complications of diabetes, and nephropathy from diabetes is the leading cause of chronic kidney disease in the US, and it accounts for over 50% of cases in the developed world. And along with diabetic kidney disease or nephropathy, unfortunately, there's also a higher risk for morbidity and mortality due to cardiovascular disease, and as a result, costs of care can be fairly high. Next slide. So how do we try to stave off progression of a complication or a diabetic complication? That will be with monitoring and controlling blood glucose levels. And next slide. So how can we do it? How do we control blood glucose levels? And if we do it, what can we prevent? We do know that when we tighten glucose blood control, blood glucose control, or keep it in a good range, it can reduce that microalbuminuria I had mentioned earlier, which is that small amount of protein in the urine, by 1/3. Next slide. Also, if a patient or people have microalbuminuria already, you can reduce the risk of progression into higher amounts of protein in the urine called macroalbuminuria by half when you control blood glucose levels. Also, there have been studies that showed when you tighten glucose control, you can even reverse microalbuminuria. So all good news. When you can control your blood glucose levels, there is some staving off of progression of kidney disease. Next slide. So how can we do this? How do we measure blood glucose levels so that we know we're in good control or not? And this probably all looks fairly familiar to all of you, but there is three, I say, broad categories of how you can monitor blood glucose levels. One is through a glucometer with finger sticks. Another is by hemoglobin A1C, which is a blood draw. And the newest kid on the block, I say, is by continuous glucose monitoring. I'm going to focus more on the hemoglobin A1C and CGM, since this is where we're looking into further with studies that we have going on at the center. Next slide. So hemoglobin A1C, just to give you a brief overview, it is a very reliable test. It's been a widely established measurement of glucose control in diabetes. It's the gold standard. So when a patient has a diagnosis of diabetes, to use this to say you're in good control or you need improved control, again, the gold standard. And you can see on the right side, we also use it for screening. And with the normal range, we call it, it's when the percentage score is lower. So if below 5.7, and when the number is higher for hemoglobin A1C, we could just say that your average glucoses are going to be higher. So with prediabetes, you can see the percentage is higher for range when at 5.7 to 6.4. And when you have a diagnosis of diabetes, it would be at 6.5% or higher. Now, if someone is asymptomatic, you would need to verify that another time to say a person may have diabetes. Next slide. So how do we know about glucose control through a hemoglobin A1C value? So hemoglobin A1C, it reflects the amount of glucose bound to hemoglobin in red blood cells, and red blood cells turn over every 2 to 3 months. So we know that the level of glycemic control, it's a reflection of 2 or 3 months prior when we draw an A1C. Next slide. So again, I just said it's a gold standard, but there are some caveats, maybe some limitations when there's chronic kidney disease present. What we can see is that with chronic kidney disease, there can be accelerated red blood cell turnover. So the life of the red blood cell is going to be shorter. So there's less time for the glucose to attach to red blood cells. So potentially the A1C can be lower than expected. And an example that I can give is, say I may have an individual with chronic kidney disease. Perhaps their A1C could be 7%, which for us, it means an average blood glucose of 150s over the last 3 months, 2 to 3 months. But say you look at this person's CGM or finger stick glucoses, and could you potentially see averages that are a bit higher as a result of the accelerated red blood cell turnover? So just something to keep in mind. And the next slide. So again, we do monitoring of blood glucoses, management through CGM or continuous glucose monitoring. And this is where an individual would wear a sensor on the skin, which could be placed on the abdomen, on the upper arm. And this one in particular is showing the Dexcom sensor. There is one that is called a Freestyle Libre sensor that is being used with the study that I will mention later on. And that one is a quarter-size white button that you may place on the back of the arm. And when that is placed, it is measuring the glucose in the interstitial fluid around fat cells. And there's an algorithm and an estimation of what the blood glucose is concurrently. The transmitter then wirelessly sends that information to a monitor. We can download all those glucose readings and gather a lot of information actually that way. Again, we are measuring glucose every few minutes, so a lot of the time periods that we may miss when a patient does finger sticks once or twice a day, we're now getting over the 24 hours per se. And then we can look at trends when a patient may have low blood glucoses or high glucoses. And we can also look at numbers like average glucoses and time in range. So it's a very helpful printout or report that we can get from someone who wears a CGM. And next slide. So for us, how are we trying to find an answer through clinical research? Next slide. We are conducting one study out of several or many studies at our center, which is interpreting glycemic control in people with type 2 diabetes and chronic kidney disease, glycemic control in type 2 diabetes and CKD for short. And the goal of this study is to look into the relationship between blood glucose as measured by CGM and A1C in patients with a certain level of chronic kidney disease and in patients who have type 2 diabetes. And patients who are future participants are people who may have type 2 diabetes, and can be on any medications or even diet controlled. It is funded through the Latham Fund, which supports projects throughout the DC metro area. Next slide. So with the help of the CGM device, we want to better understand if A1C values are significantly different in persons with diabetes and chronic kidney disease compared to the average glucose data captured from the CGM. And are these differences in average glucose and A1C dependent on stage of kidney disease? So that's a secondary aim we have there. Next slide. We are having this study being done at 2 separate sites within MedStar Community Clinical Research Center, or MCCRC, which is the scientific research center within MedStar Health Research Institute, the research arm of MedStar Health. So we are doing this at the University Town Center location in Hydesville, and then at MedStar Good Samaritan Hospital in Baltimore. Next slide. And if one should choose to be involved, you would have a placement of a continuous glucose monitoring device for continual glucose measurements over about 2 weeks. It can be 10 to 14 days. We are looking for 40 participants. And at the screening visit, we will proceed once information is provided, all the questions are answered, and as long as the patient provides consent, and we will do this prior to any study procedures. Next slide. So at the first visit, once consent is signed, we would draw a blood sample for an A1C and kidney function, and we may draw a sample for hemoglobin and hematocrit. And this depends on whether the participant already had these tests drawn within a month prior to the screening visit. You would attend 3 study visits over the course of 2 to 4 weeks, a short study. Next slide. Just some more information about the CGM. It would be a blinded CGM, meaning that you won't be able to check your blood glucoses at the time you're wearing it. We would definitely go over all the information from the report after the study participation, and also provide that information to endocrinologists or internists who are involved in the care of the participant. And this slide is about COVID-19 safety measures. We, of course, have had a number of questions around this and research participation. We are now a year going into COVID-19 pandemic, and we have been keeping up with this just as MedStar Health has throughout all of the hospitals and centers. Masks are mandatory. We do screening calls. And over time, of course, there have been protocols extending out to even converting clinic visits to phone visits at times. And the next slide. So if you're interested in learning more, would like to participate, please contact our research coordinator, OC Sanchez. Number is provided, or an email to OC Sanchez, and we'd be glad to talk to you more about our study. Thank you.